Vanessa, can you hear me?
Hi there. Yes, I can. Am
Okay.
I coming in loud and clear?
Yes, I think we are ready. We have attendees. Hello, everyone. This is Christine with HAFA. I'm going to give the floor to Vanessa.
Well, very good. Well, Christine, thank you so much. And Ronell, I appreciate the opportunity to present to you today. I am going to just wait for a couple of minutes because if attendees are like me, they typically sign on right at the top of the hour and the speaker's going on and has already covered quite a bit of ground. So I'd like to just give everyone a couple of more minutes, if you don't mind, Christine. Oh, sure. I'll just check back in about 1 minute. All right, thank you so much. All right, it is 3:02 Eastern Standard Time or 2:02 Central Standard Time. My name is Vanessa Parker and I am the Regional Sales Director for Excelsior Senior Brokerage. Excelsior Senior Brokerage is a subsidiary of Health Markets and we are located out of North Richland Hills in Texas. I've been in the insurance industry since 1987. I actually started with the Blues. I was with them almost 10 years. And when I left the Blues, I started my own insurance agency in the small and large group market segment, designing employee benefits for those companies. And then from there, I actually moved down here to Florida. And for those of you familiar with Florida today, I'm out of the Tampa Bay region and it is very cold here. I've got my space heater going. I know that's very pathetic because I'm sure many of you are in some very cold areas in the country, but it's cold for Florida here. And I had to cover some of my plants last night. So today we're actually going to be talking about MACRA. And MACRA is actually the Medicare Access and Chip Reauthorization Act of 2015. And I'm going to be going over specifics of this legislation, specifically the new ID cards, the MOON, which is the Notice for Observation Status, what happens to Medicare plans after 2020, IRMA, which is Medicare beneficiaries may have to pay more for Medicare Part D and Part B, changes to the inpatient payments, which is the hospital payments quality payment system, rating of doctors, and how it repeals the sustainable growth rate formula. And then I'm going to leave you with the top 5 things to do now and a little brief summary. This should not take more than 30 to 35 minutes. So just sit tight, grab yourself a cup of coffee or a glass of water and let me go on and talk to you about MACRA. So what is MACRA? As I said, it does stand for Medicare Access and Chip Reauthorization Act of 2015. And it was established in 1997 to control Medicare payments, which were costs. It was a bipartisan legislation signed into law on April 16th, 2015, that did replace the SGR, or the Sustainable Growth Rate Formula. The fee-for-service payment was based on volume, not value. And Congress was actually passing at that time temporary doc fixes, which postponed payment cuts. There were a 21% cut in 2016. And what we've seen in over $716 billion in total cuts in the Medicare program from 2013 to 2022. Just a little side note on that. The most significant cuts come from Medicare Advantage plans, which are $260 billion. And that will be seen within the next 4 to 5 years. And so what you're going to be seeing there in that cut for Medicare Advantage, you're going to see a shift in what Medicare beneficiaries have to pay out of their pocket for Medicare Advantage plans. And what I'm referring to is the coinsurance amounts. So when I started doing Medicare Advantage in 2008, the coinsurance was running anywhere between $2,500 to $3,200 per calendar year. For any of you who do Medicare Advantage now, what you will see is the coinsurance amount typically is $6,700. You're probably going to see that go up in the next few years. So pay attention to that, because that is going to be part of those Medicare cuts that we're talking about here. So physician payment rates. So there are a couple of different components to the MACRA bill. It's pretty complicated. I'll try not to bore you, but MIPS is the merit-based incentive payment system. So this is the one of 2 value-based tracks that is part of the MACRA legislation. So what's the purpose? The purpose is to motivate physician groups to provide higher quality care without increasing resource usage. Again, we're talking about that SGR formula. And physicians can opt out of MIPS as long as a large enough percentage of their revenue comes from qualifying alternative payment mechanisms. So alternative payment mechanisms, basically, if a doctor can improve the care of an end-stage renal disease patient or a person who has cancer, they can earn extra dollars. So APMs must require that income is linked to physician performance, and the points that they earn will translate directly into higher or lower reimbursement, depending on the reporting and the level of quality of care. What we're going to see with MIPS and APMs is that most physicians are going to select the MIPS payment system. Fewer and fewer physicians will select the APMs payment system, because it's going to be very, very hard to see the improvement in care for end-stage renal disease patients and cancer patients and things like that. Typically, physicians that do choose this path, APMs, are taking on a full risk. And there are a lot of organizations and physicians that really just can't do that, so they're going to do the MIPS payment system. So how is this going to affect seniors, our valuable clients that we work with? New ID cards. So CMS is going to begin mailing new ID cards out this year in April. They're going to start mailing them out. It doesn't mean that everyone is going to receive their new ID card in April. It just means that that is going to be the beginning of when they start doing that. The deadline for replacing the Medicare cards is December of 2019. The new number is going to contain a combination of numbers and uppercase letters. The issuance of the new number will not change the benefits for people with Medicare. People will receive that new Medicare card in the mail. It will be free. It doesn't cost them anything. And there will be instructions that will be listed on how they can safely and securely destroy their current card. Removing the Social Security number from those red, white, and blue cards is going to help prevent fraud. It's going to combat identity theft, and it's really going to safeguard taxpayer dollars. There are just a lot of people that were taking advantage of seniors because they had access to that red, white, and blue card, which had their Social Security number on with a letter on the end of it. And as you can see to the left here, the red, white, and blue card, that member number is a combination of those different letters and numbers. So those MBI numbers, that's what they're called, Medicare Beneficiary Identifier. It will be issued to all existing members. The MBI is that random number generated using 11 characters. And as I just mentioned, currently it's that Social Security number with 1 letter or sometimes 2. It will be done between April of 2018 and December of 2019. After January 1, 2020, the old Medicare card will not be accepted. So these are some things that are really, really important for you to know. But I think probably the most important thing that you need to tell your clients insurance companies are going to have to change everything. That's a big deal because applications, billing systems, claim systems, all of that needs to be changed to make room for the extra digit. So I have a lot of friends that I've worked with in the carrier world, and a lot of the IT people are frustrated right now because they realize that this is coming due to MACRA legislation, and they're working very, very hard to make changes to that billing system, claims system. All of the IT systems will be affected by the new 11-digit number and letter, or should I say MBI. So how is this going to affect seniors? So Medicare Observation Notice, or MOON, Outpatient Observation Notice. So under Medicare law, and as you may or may not know, seniors need to be in the hospital at least 3 days, not including the day they are discharged, in order for Medicare to pay for a skilled nursing facility. However, under current Medicare rules, acute care hospitals are increasingly holding patients under observation. Now, I do want to make a little side note. I would highly recommend, when you have a moment, go to YouTube, type in inpatient versus observation, and see all the videos that are out there from all the different news organizations, individuals, people that have posted videos regarding inpatient versus observation. It's staggering. People are paying $20,000, $30,000, $40,000 for skilled nursing facility because they went into the hospital. Let's say they had a broken leg and they received care for 2 days or more, and then they're released and put into a skilled nursing facility. And when that happens, what do you think happens? If they're placed under observation while they're in the hospital, their skilled nursing facility typically is not covered. They have to be in the hospital 3 days and classified as inpatient in order for their skilled nursing facility to be covered. So go ahead and take a look online at what they have under YouTube, inpatient versus observation. And if you are an agent that is out there selling hospital indemnity plans, for example, the inpatient versus observation videos that are on YouTube are an outstanding sales tool in showing your Medicare beneficiaries an example of what happens if they're not adequately covered with a hospital indemnity plan, for example. I don't want to read every single thing here because it would get too lengthy, but you can see here some examples of a situation number 1 and situation number 2, if the skilled nursing facility stay is covered and if it is not. And you can see it's pretty much what I've just been discussing here. This is one of those videos. I'm not going to play the video, but you can go ahead and take a picture with your cell phone and you can see for yourself that that is a video that is about 2 minutes and 30 seconds long. It's the perfect video to show to a Medicare beneficiary with regard to this situation. So in 2015, there were more than 600,000 cases actually where patients were in the hospital for 3 days or more, but they were not eligible for skilled nursing facility or rehab because they were put under observation. So what the Center for Medicare Advocacy did, and by the way, that is an excellent website to go to. In the bottom of the corner of this presentation, you'll see lower left-hand corner, my source was actually the Center for Medicare Advocacy. I found a lot of this information on there. There's a notice regarding observation status. So when a person is brought into the hospital and they're overnight, it is a requirement now that the hospital let them know whether they're in observation or whether they're inpatient. But there are some problems with this notice. It's not perfect. We're trying, Center for Medicare Advocacy is trying to make it so that they cannot do this to Medicare beneficiaries, but not all outpatients are going to receive a notice of non-inpatient status. Only hospital patients who are classified as receiving observation services will receive that notice. And patients who are just classified as outpatient, even for many days, are not required to get the notice. So it's a little tricky, and everything is not set in stone yet. But trust me, there's a lot of Medicare advocates out there really trying to change legislation even further than MACRA so that Medicare beneficiaries. This is what a sample of a moon notice looks like. And so you can go on to that site on the bottom in the lower left-hand corner that I've indicated, and you can actually get a copy of this notice and print it out if you'd like. There is an observation stay coalition. It consists of 28 national organizations. And what this coalition does is it collects stories that put a face with the issue. And they support bipartisan legislation that would count observation stays towards the 3-day stay requirement. The supporting senators are Sherrod Brown of Ohio, Susan Collins of Maine, Bill Nelson of Florida, Shelley Moore of West Virginia, Joe Courtney of Connecticut, Joe Heck of Nevada, and they've all introduced Improving Access to Medicare Coverage Act of 2015. And so this is all in support of this observation versus inpatient status. So how else will MACRA affect seniors? Well, it affects them, with regard to Medigap plans after 2020. And I'm sure you guys have all heard of that. So let's talk a little bit about that as well. So starting in 2020, MACRA will require that new beneficiaries will no longer be offered a zero deductible Medigap plan. Under MACRA, anyone who's on original Medicare Part A and B or both by December 31st of 2019 will always be able to purchase Plan FC or high deductible F as long as they pass medical underwriting. But anyone new to Medicare after January 1st of 2020 or later will not be able to purchase Plan F, Plan C, or high deductible F under Medigap plans. So as an example, a person can be on an MAPD plan or on a Medigap plan now, and in 2024, they will still be able to get Plan F, Plan C, or higher, or high deductible F, as long as they pass medical underwriting. The change that you're going to see after January 1 of 2020 is only going to affect people that will be new to the Medicare program. So let me know if you have any questions on that at the end of this, all right? How will MACRA affect seniors? IRMA, Medicare beneficiaries may have to pay more for Medicare Part B and Part D. So IRMA is the income-related monthly adjustment amount. When a Medicare beneficiary's monthly modified adjusted gross income is over a certain threshold, they will pay more for Medicare Part B and Medicare Part D. So summary, MACRA does affect that income-related monthly adjustment. The change will occur after January 1st of 2020, and the look back is going to be 2 years. And unfortunately, we don't know the exact number for the new threshold, but some believe that it actually will be decreasing. And more people on Medicare Part B and Part D will pay higher premiums. So that is what we do know. The Part B and Part D premiums will be going up. What are the changes to inpatient hospital payments? And what about Medicare ratings of doctors? So the Quality Payment Program, or QPP, changes the way Medicare rewards providers for value over volume. There will be a star rating for doctors as well. So just like Medicare Advantage plans are star rated, doctors are going to begin to be star rated as well. Streamlines multiple quality payment programs under the new merit-based incentive payment system, and it also gives bonus payments for participation in eligible alternative payments, APMs. We went over that a little bit earlier, but I'm going to go into it a little bit more because this key point of the QPP really does talk in detail about MIPS and APMs. And then finally, electronic health records. It's going to require physicians to move to EHR, or electronic health records. CMS did propose these changes to the 2018 program, including waiving the EHR requirement for a whole other year. So the EHR is actually really, really important. And that is because, as you know, coordination of care is an issue in this country. If you or a loved one that you know of has ever been sick or ever had any kind of treatment whatsoever, you'll know that not all pharmacies communicate with all doctors' offices. Not all doctors' offices communicate with specialists, and so on and so forth. So a person can actually go to a pharmacy from a specialist and pick up, prescription drugs, and then go over to another doctor's office and get an order for another drug, which is then issued, and go get it at a different pharmacy, and so on and so forth. And it's just crazy. And part of that is because there is no coordination of care with regard to electronic health records. There will be a tie-in into the system. Now, some people think that this is bad, and some people don't. But I still know of doctors' offices that I can walk into, and all of their files are on paper. Just think about your dentist's office. Many dentists' offices still have paper that they're working with. They're not doing electronic health records. What this basically means is very, very similar to what we've seen in the motor vehicle division system of the United States. You know, how many people do you know many, many decades ago that got in trouble in one way or another with the motor vehicle system? And now you can run, but you cannot hide because everything is tied together. Well, the electronic health records is going to be exactly the same thing. It's just going to be with regard to your medical records. It is all going to be online. And so part of this legislation is all part of that. So what is the implication with QPP and MIPS? So the law requires that Medicare clinicians choose one of two major value-based tracks. And we talked about this earlier in the presentation, MIPS or APMs. So what does this mean? Well, the merit-based incentive payment system is actually based on 4 different things. It rates providers on clinical quality, information technology use, clinical practice improvement, and research use. And it combines the elements of the meaningful use, or MU, and the physician quality reporting system, which is the PQRS, and the value-based modifier, VBM. So it rates them based on the different points that you see down below there. And the MIPS scoring and related payment impacts, they're definitely not one-to-one. Even a 1/10 of a point of a difference in a clinician's performance can influence their Medicare Part B reimbursement under MIPS. Now, MIPS does not apply to Medicare Advantage plans. So do want to make that perfectly clear on that. Advanced Alternative Payment Modules, or APMs, it includes other value-based programs, such as Medicare Shared Savings Programs, or ACOs. Qualified participants in advanced APMs, which will carry their own advantages and disadvantages, will be exempt from MIPS. Practices earn more by taking on additional risky patients, such as patients with end-stage renal disease or cancer. Practices can earn up to 5% incentive payments in further improving patient care, and advanced APMs are less likely. So most practices are actually going to be on the MIPS system, just as I mentioned to you earlier. Measurement for the MIPS final score will begin January 1, 2017. So it actually started last year. And the payment incentives, or the penalties, are going to take effect in 2019. So the final score could result in incentives that actually could reach up to 37% for Medicare Part B payments by the 4th year, but the penalties can grow up to 9%. So although there are going to be incentives for physicians, there will also be penalties as well. So how does the QPP impact Medicare beneficiaries in the selection of doctors? Well, like MAPD and PDP plans that are star rated, doctors will be rated as well. So let's go over each one of these points. The ratings are going to determine if a doctor will receive bonuses or a penalty. So obviously, if they're rated low, they're probably going to get a penalty. If they're rated high, they're going to get bonuses. Each clinician's annual final score performance will be released to the public by CMS, and that's going to impact professional reputation. As physician payments become at risk, an increasing number of physicians may decide to seek employment or contractual relationships. And what I mean by that here is probably with associations or with hospitals. So the time of the small-time doctor who is not part of an organization or a hospital is going to be far and few between. 65% of consumers are aware of online physician rating sites currently, and 36% have used a rating site at least once. Damage to a clinician's online public reputation could take years to reverse, but conversely, consistently high performance scores and ratings could become a strategic advantage over local competition. So what are the top 5 things that you can do now for your Medicare beneficiaries? What you can do is when you sit down with your Medicare beneficiaries, you can tell them that they're going to be getting new ID cards. You can tell them the time frame is between April 2018 and December 31st of 2019. They'll receive ID cards, they'll receive notification on how to destroy their old ID card, and you can tell them the reason is because of identity theft and just really to protect them from identity theft. You can let them know that if they go into the hospital and they're placed in observation, they will be receiving the moon, basically. And that's basically a notice of observation status. Let them know that they should also mention this to their power of attorney, their guardian, their healthcare advocate, their son or their daughter, whoever it is that it helps them make their healthcare decisions, their healthcare advocates. Those are the people that should be really hearing this information in addition to your Medicare beneficiaries. Also let your clients know that if they're on Medicare supplements now or on a Medicare supplement, that after 2020, there will be no more zero deductible Medigap plans available. But if they're on a Medicare plan now with a supplement, that they will be able to move to FC or a high deductible F in the future. If their spouse, though, turns 65 after January 1, 2020, their spouse would be considered new to Medicare and will not be offered those plans. So it's really, really important that you, differentiate that for them so that they understand, because there are a lot of clients out there that you probably work with who has a spouse that's significantly younger than they are, and they'll just automatically think that their spouse will be eligible for what they're eligible for. That is not the case. If a person is new to Medicare after January 1st, that person will not be able to get zero deductible Medigap plans. And finally, premiums for Medicare Part B and Medicare Part D may go up. Let them know that if they earn over a certain threshold, that their premiums could go up. If you're wondering what those thresholds are, I didn't cover it today because it would just take way too long to go over that information, but you can go to the Center for Medicare Advocacy. Just type that in on your browser and it will come up, and you can go right to the section that addresses this issue. It has the annual salaries in there for high income earners, and pretty much for the most part, many Medicare beneficiaries who earn over a certain amount are the ones that are going to see an increase in their premiums. So MACRA does represent the largest transformation in a generation to how Medicare providers are paid and what Medicare beneficiaries will expect with regard to these changes. As I mentioned, CMA is a great location to go to online that will tell you information with regard to this. You can also call the number listed on my screen as well. That's a very, very good number as well. So my summary, and I'll be done and open this up for questions, is while docs fixes are a good thing, since it makes doctors provide higher quality of care without increasing usage or visits, this legislation shifts the cost to Medicare beneficiaries, while private insurance companies and drug companies profit from Medicare but contribute nothing. While the legislation stabilizes physician payment and moves towards value over volume, it does so by requiring too much from Medicare beneficiaries without enough in return. I think it goes without saying that what we're seeing is the shift in costs is essentially going to Medicare beneficiaries as we move forward into 2020. And I know that a lot of you out there see your Medicare beneficiaries on a regular basis. You review their coverage on a regular basis. It's hard news to give to Medicare beneficiaries, as we know so many of them have low incomes and already are finding it very, very tough to purchase insurance. Unfortunately, the shift in cost is going to impact them greatly. It is something that we kind of have to ease into, and hopefully I've helped you to understand a little bit more about some of these changes that are coming in the future. I hate to be the bearer of bad news, and I know I'm a little early with bringing this news to your attention, but I also think it's important that we learn to live with what is happening in America today and what we are seeing out there as a result of the MACRA changes. I'm going to go ahead and open it up for any questions. I want to thank you so much for coming on with me today. And if you have any questions at all, feel free to send them over to Ronelle and she'll reach out to me, or you can reach me directly. Thank you so much, and I'll go ahead and open it up for questions. All right, so if there are no questions, then I will go ahead and turn this back over to Christine. Christine?
Thank you so much, Vanessa. I don't see any questions on our end, but if anyone does think of anything later, they can either email me or contact you. They have all your contact information. And thank you so much for the information, Vanessa.
It was my pleasure. Thanks so much as well. You guys all have a great day.
You too. Bye-bye.
Bye-bye.